one and all present in this session. I'm Ankita from Planet. Planet is very proud to be a part of this webinar as a digital partner. Now I would like to present to you all a short video of Planet. Thank you so much for all of your patience. Planet is India's largest live digital CME and doctors generated medical content platform. Our website is www.planet.com, where we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only, that also you can read in your leisure time. We will invite all the doctors to visit our website. Now, without any further delay, I would like to hand over the session to Sir Dr. Prashant Kaiya, sir. Thank you, sir.
Thank you so much. On behalf of NNF Gujarat, I, Dr. Prashant Kaiya, the Secretary of NNF Gujarat, welcome one and all to today's Neonatal Pathshala PG case presentation. Those who are on YouTube and ClearNet platform can pose the questions, and our experts will be answering that at the end. We are also lucky to have our advisors, Dr. Somsekhar Nimbalkar and Project in charge, Dr. Yogesh Parikh sir, with us. So we welcome them also. Today, Dr. Vilas Kawar, she is a fellow in neonatology in Nirmal Children's Hospital, is going to present a case in neonatal case presentation mentored by Dr. Mohit Sani. We are having two experts with us today. Our first expert is Dr. Dhananjay Mangal. He has done his MD from the SMS Medical College and then Fellow of Indian College of Maternal and Child Health. He is actually at present the Honorary Secretary of National Neonatology Forum Rajasthan State and Honorary Secretary of National Neonatology Forum Jaipur City Chapter. He is a director of Babylon Children and Perinatal Center Jaipur. He is having a keen interest in neonatology and he is trained in PALS, NALS, PFCCS, CON and Neonatal Eco, and he has also done a clinical observership at Great Ormond Street Hospital, London, UK. So we welcome, sir. Sir, we are glad that you are with us today.
Thank you very much. Thank you.
We are also having our second expert, Dr. Ravi Sachin, with us. Ravi Sachin is a professor in the Division of Neonatology, UCMS and GTB Hospital, Delhi. He is having today an exam, so he'll be just joining in around 15 minutes. He is an external executive board member of NNF India and chairperson and member of various standing committees of NNF. He was a vice president of NNF Delhi in 2022 and secretary of NNF Delhi in 2020 and 2021. His areas of interest are actually a quality improvement in maternal and neonatal healthcare. So we welcome Dr. Ravi Sachin with us. So as Dr. Ravi is joining slightly late, Dr. Dhananjay, Dr. Somsekhar and Dr. Mohit Sani, they are our advisors, but they will be with you for PG case presentations, and Dr. Ravi will be joining soon. So I request Vilas to start the presentation. Thank you.
Yes, just wanted to make a clarification. I'll leave it around 4 o'clock for another meeting, so please excuse me for that. So anyway, go ahead. Thank you.
Yeah. So Ravi will be joining in around 15 minutes, and then sir, thank you so much for at the last minute agreeing to be an expert instead of Ravi Sachin. Yeah, thank you.
Okay. Good afternoon, everyone. I'm presenting the case of baby of XYZ, female baby, now 42 days old, born of a non-consanguineous marriage to a 31-year-old primary mother via lower segment cesarean section at 27 plus 5 weeks of gestation with birth weight of 810 grams. Mother's LMP was 17th of July 2022 and EDD was 23 September 2023. Mother blood group was B positive and baby is also B positive. Baby was admitted to NICU in view of respiratory distress in preterm care. Antenatal history: mother's age was 31 years and active married life is 2 years. Pregnancy was registered at outside hospital and total antenatal visits taken were 26 every 15 days till 26 weeks and then daily till delivery. Mother is well built and weight gain during pregnancy was 6 kg. Pre-pregnancy weight was 59 kg. during first trimester, mother is a known case of type 1 diabetes mellitus. She is on insulin. Mother had a hypothyroidism, which was detected during pregnancy, and tablet Thyronom 100 microgram was started. No, there was no history of excessive vomiting, fever with rash, any exposure to drugs or radiation during pregnancy, or a triple marker HIV, HbSAg, and VDRL was negative. Folic acid supplement taken during pregnancy. There is two antenatal scans were done during the first trimester. First at 6 weeks, and then second one at 12 weeks, which were normal. In second trimester, quickening felt at 16 weeks of gestation. TDF2 doses were taken at a 1 month interval. Iron and calcium supplements were taken. There was history of PIH, which was detected during second trimester. For that, tablet labetalol and tablet nicardia was started. There was no history of UTI, fever, bleeding PV, and leaking PV or anemia during pregnancy. At 18 weeks, anomaly scan was done, which was normal. Triple screening was done, which was negative. In third trimester, steroid, one course of dexamethasone, 6 milligram intramuscular, 4 doses 12 hours apart, given at 26 weeks of gestation. There was no history of UTI or leaking PV during third trimester. Birth history, emergency lower segment cesarean section was done at 27th of January 2023 at 9:21 p.m. in view of reversal of diastolic.
So I just wanted to ask you a question. We can just have a small break
Yes,
over here and discuss the case. So in terms of EDD was in September, is that correct?
Sorry, sir.
EDD was in September, is that correct? September 27th September. Expected date of delivery is that. So and baby was delivered on what date? Baby is already 42 days old.
27th of January, sir.
And you said baby was born at 27 weeks.
27 plus 5 weeks, sir.
27 weeks and 5 days, is that correct?
Yes, sir.
So,
Yes, sir.
So EDD would be more 12 weeks after the date of birth. Correct? After the current date of birth. I'm a little confused with
yes, sir.
Because what was the date of birth you said?
It's the 27th of January.
So, sir, EDD calculation is wrong. 23rd April 2023 is EDD, not September. Yeah.
Yeah, because she said September, so I was quite confused as to how that.
So it is 23rd April.
Okay. Wait, so that's a big gap. Anyway, so other question that I wanted to ask is before that is you mentioned that dexamethasone was given before the birth history. Correct. Now, why was dexamethasone given?
Sir,
indication for dexamethasone?
Sorry, it was given because of it was high risk pregnancy, and during that to mature for maturity of the baby's lung and for further postnatal benefits, we are giving dexamethasone to a mother for that.
Sir is asking.
What is the question?
Why dexamethasone is given, not betamethasone? What is the ideal rate to give for antidepressant?
Sir, yes, sir. Ideally, betamethasone is to be given, but for betamethasone, first of all, it is costly, and it has two salts, acetate and phosphate. In India, phosphate salts is not available, so it is not more helpful. So we are giving dexamethasone, sir.
So the question is, when there is anticipation of delivery, then we give dexamethasone. Then we expect that there is going to be labor. So was labor expected in the next week, and hence dexamethasone was given? That is one question. Or was it just given regularly?
So usually after 26 weeks. So usually recommendation is after 26 weeks of delivery gestation, we can give a steroid cover to a mother.
Okay. Okay. That's anyway. So another question that I want to ask is, do you know that this is, I think you might not know, but it would be interesting to read. Before 32 weeks and after 32 weeks in utero, the way in which the brain receptors react to steroids is completely different. and hence giving doses of steroid in anticipation may actually cause a lot of harm. This is there in Clinics in Perinatology, published in 2018 or 19, some years back. So I would just urge you to read role of steroids during antenatal period and use from Clinics in Perinatology. So anyway, Dr. Dhananjay, would you agree giving steroid dexamethasone without an anticipation of any kind of labor?
No, basically, if expected within a week or within 48 hours to 72 hours, we have to be completed this dexamethasone.
Yeah, so just because it's 26 weeks, I don't think there is an indication to give dexamethasone. I mean, that is what is concerning. If there was an indication that there is likelihood of labor in the week, or there is some issues with holding the pregnancy, there's no point in giving. You got my point, what I'm trying to say. You will not give dexamethasone to any pregnant woman with 26 weeks of pregnancy. You would only give in those who are likely to deliver in the next week or so, or in whatever, within a week if they're likely to deliver. And that is the indication. That's what I would ask.
Sir is asking whether mother, when the dexamethasone was being planned antenatally, whether there was any indications that she is going to deliver soon, or it was just given without any labor. This is what sir is asking.
Sir, it was a high-risk pregnancy. First of all, it was IVF pregnancy. Mother is diabetic. There was also hypertension detected during second trimester, and that's why, considering high-risk pregnancy, steroid during steroid was given after 26 weeks of gestation, sir.
So after the steroid dose, within how many days mother delivered?
Sir, after 1 week.
After 1 week. Okay.
Yes, sir.
Fine. So is there any indication of repeat steroids?
Sir, there was no indication.
Suppose mother had not delivered after 1 week, but she has remained pregnant till say 32 weeks or 34 weeks, till 33 weeks. So would you advise another dose of dexamethasone or betamethasone?
Sir, yeah. Yes, sir. Yeah, we can give, sir, one rescue dose of dexamethasone after 14 days of first course of steroid.
Okay. All right. I wouldn't agree so much. It has neurological issues giving repeat doses. People give. I'm not saying people don't give. But I don't think there's a lot of evidence to support it. Anyway, Dr. Dhananjay, if you want to ask anything, you can ask or you can go ahead.
Yeah, Dr. Vilas, what is the indication of the MAC self in this case?
Sir, a mother has a severe PIH, and there was a mother has severe PIH. That's why magnesium sulfate was started before delivery for neurological protection of baby.
For this case, it's not indicated, right?
Yes, sir.
Because mother was on a levodopa and
Nicardia.
So, is there an indication for the MAC self, particularly in the 27 week of age?
Yes, sir. We can give in pregnancies less than 32 weeks of gestation. We can give magnesium sulfate for severe PIH to a mother. So if delivery is emanating if we are expecting that baby will be delivered within 24 hours or so.
So in this case, you are not expecting not to be given Maxil because not expected to deliver within 24 to 48 hours, right?
Yes, sir.
So sir. So what about what is the clarification about this? Can you?
So magnesium sulfate is supposed to be a neuroprotective. There is a lot of evidence to say that it is neuroprotective. So I think that is one of the indications that it is often used for just during delivery time. So and that's what is the evidence. So anyway, Mohit, any comments on this?
Yeah, like self now, sir, it is in the protocol of most of the like in American, European guidelines, most of the guidelines have obstetric gynec societies of all over the world. Now it is less than 30, some say 30 weeks, some say 32 weeks, less than 1.2 kg. If the baby is getting delivered, then we give Maxel, we load and then we give Maxel for 24 hours or delivery, whichever is earlier. if the baby delivers.
Yeah, and,
So it is indicated. It is indicated in most of the guidelines.
and it is mainly for neuroprotective effects to the baby, and
Yes,
not
baby, not for the mother.
Not for the mother. So I think that is
Not for
what
the
we
mother.
need to stress.
Yes,
Pehle
it is not
काफी
for the
बार,
mother.
I think initially a lot of people used to use it for the mother and for various for PIH and all, but now it is indicated for the baby. Neuroprotective effects are there.
Yes, it is
And there were a lot
purely
of
for
issues
baby.
for the baby. There were a lot of issues earlier that people used to worry about myself and all. I don't think the issue about being adverse effects, etc., is borne out. It's pretty safe that you could be given properly and monitored well. Yeah, please. I think that's what you wanted, Dr. Dhananjay.
Okay. During follow-up, ultrasound was done, which was suggestive of a Doppler study was done, which was suggestive of reversal of diastolic flow in umbilical artery. So delivery was done at 27 plus 5 weeks of gestation. Female baby with birth weight of 810 grams was delivered. Baby cried immediately after birth. Apgar score was at 1 minute 6 and 5 minutes 8. But due to the secondary apnea, bag and mask ventilation was given, followed by intubation and intermittent positive pressure ventilation. Course in NICU, baby received intubated in NICU. Within 2 hours of life, surfactant was given, and gradually, initially baby was put on ventilator at a volume guarantee mode, volume of 5 ml per kg, and after surfactant, ventilator parameter was tapered gradually, and baby was extubated at 18 hours of life, and baby was put on non-invasive ventilator with pressures of 15/5 and backup rate of 20. And gradually, rates of non-invasive ventilation and pressure was tapered, and baby was put on CPAP on day 6 of life. And baby was stable on CPAP, and so high flow trial was given on day 8 of life. But due to the repeated episodes of apnea, baby again put on non-invasive ventilator. And gradually, again, baby was weaned to the bubble CPAP on day 13 of life with PEEP of 6. As baby improved, PEEP was tapered to from 6 to 5 on day 20 of life and day 16 of life. And after 4 days, baby was put on high flow on day 20 of life. And feeding was started at 12 hours of life. Minimal enteral nutrition was started at 15 ml per kg per day and gradually increased. And baby was on full feed on day 7 of life, full RT feeding. And then fortifications were started on day 8 of life, but due to the repeated episodes of apnea on day 8, baby was again put on feed volume was reduced to half, and IV food were started. And then baby RT feeding. After that, baby kept NBM because of abdominal distension. And then on day 13 of life, RT feeding restarted. As in birth history, vitamin K was given as discussed. Baby was put on ventilator and chest X-ray suggestive of RDS stage 3, and Silverman-Anderson score was 7. So surfactant was given and ventilator parameters was tapered. UVC was secured after admission, and injection febrinil was started. As baby was in shock, as feeble pulses and capillary filling time more than 3 and tachycardia, low vitamin at 10 microgram per kg per minute was started. At that time, blood gas suggests a pH of 7.12, CO2 of 42, O2 46, and base deficit of minus 15.6. Blood culture was sent, and first line antibiotics were started, and amino 1 at 2 gram per kg per day, injection caffeine and injection febrinil given. Initial septic screen was negative. At 15 hours of life, 4 units of FFP, 12 hours apart, were transfused to the baby in view of coagulopathy. INR was 1.9 and APTT of 150 seconds. 2D echo was done at 14 hours of life, which was suggestive no PDA. And at 18 hours, baby was extubated to non-invasive ventilator. Phototherapy, double surface phototherapy, given at 23 hours of life in view of hyperbilirubinemia. At 24 hours of life, screening had ultra.
Yeah, so just wanted to ask a few things because we are going pretty fast, and I just wanted to use your written DSPT, double surface phototherapy. How do you measure phototherapy actually? Most of us use the word single surface, double surface, but if you want to actually measure the amount of phototherapy, how do you measure phototherapy? whether high intensity phototherapy is going on, or how do you measure it? कैसे
Sir,
measurement होता है to say that we are giving?
Sir, according to bilirubin value, as exchange transfusion and phototherapy, we are deciding that baby require single surface or double surface intensive phototherapy. For intensive phototherapy, we are keeping distance near to the baby up to 20 centimeter from baby to phototherapy.
So my question is actually
And the
intensity. You
minimal
mentioned intensity. So how do you define high intensity phototherapy or maximum intensity, whatever terminology you might be using? Double surface, single surface phototherapy is a terminology we use in our local, whatever we use for convenience. But ideally, you're supposed to say high intensity or whatever, something like that. So is there any definition to say that itna hota hai to usko baad high? Because I think it is given in one of the manuals. Quality manual probably defines it as high intensity phototherapy. Some
sir,
people define it in different ways.
phototherapy.
ऐसा कुछ होता है? हाँ.
Yes, sir. Wavelength of phototherapy for intensity, high intensity, 460 to 490 nanometer. Irradiance of light is 30 microwatt per centimeter square per nanometer. And distance from the baby is ideally 20 to 30 centimeter. For high intensity, we are keeping distance of 20 centimeter with maximal exposure of the body surface area, only covering the eyes and diaper. Yes, that's all, sir.
I think different books. There are some books which mention more than 30 meter square of irradiance and 35 to high for high radiance. So that is what you would require to get. So that is what I would think. So Dhananjay sir, any particular thing? Because
So I think, sir, you were asking regarding the how will you decide whether it is double surface or single surface. What does it mean? I think so. It's a borderline and prophylaxis case in extreme premature baby. Then we can start the single surface or one side, right? So phototherapy means phototherapy is to be covered whole body. And what are the standard Dr. Bilas has been explained. So that has to be utilized. I think so. There is no clear-cut guidelines about the single surface phototherapy and double surface phototherapy. Is there, sir?
So there are 2-3 points I just want to add on. So one, Vilas, what Vilas you have just told, the distance. So the distance was basically for CFL phototherapy when we used to use CFL. So all those distance criteria is for CFL. Since we get LED, that distance criteria is gone now. Since we have started using LED phototherapy. So in Kolati, that is for CFL. And what sir wanted to ask, Dr. Somshekar rightly said, because ideally there is no term of double surface, triple surface, single surface. It is low intensity and high intensity. And most of the literature or books, they say low intensity is less than 30 radians and more than 30 is high intensity. So this is what is the terminology it is being used. So we locally, we have converted it as single surface, double surface, triple surface. But sir has rightly asked regarding this. And the distance criteria is only for CFL, not for LED.
Yeah, so there are some books which mention 35, some books which mention 30, but so the whole point is what I wanted to ask you, what do you think? So, and that you have to measure irradiance to say whether it is high intensity or low intensity. So we, for all practical purposes, say double surface, which usually might correlate to more than 30 or more than 35 microwatts per centimeter per square, that kind of irradiance. So we require to give high intensity phototherapy when we go to double surface, or some people, sometimes people say triple surface also, whatever. So that we want to achieve. And as sir mentioned, long time back, I think 30 years back, when people used to teach about phototherapy, they used to ask distance of phototherapy. It used to be 45 centimeters. Now, there is distance actually does not matter. It has to be enough distance so that you can see the baby, monitor the baby, and you should be able to lift out the baby for any kind of phototherapy. That is one. With LED, you can place the baby on the LED blanket, or it can be kept very close. Advantage of LED is you don't get high temperature for the baby. But with CFL and all, sometimes baby can get heated up quite a bit, can have diarrhea, and because of we'll have diarrhea many times. We'll discuss that a little bit later. But we'll get heated up significantly and we'll get irritable, which we want to try and avoid. So that's something which we should get. So you have to understand the concept of irradiance to say that baby is receiving high intensity phototherapy or low intensity phototherapy. Yeah, I think you can continue.
Yeah, so just one thing, we welcome Dr. Ravi Sachin. He has joined. So welcome, Dr. Ravi.
Thank you. And so I can step out of the meeting, I think.
No,
Thank
sir,
you.
you be there.
I'll be there. I
join.
have to go to the meeting. Go to another meeting. Yeah. Thank you.
So, yeah, Dr. Ravi is there. Yes. Yeah, Dhananjay sir want to ask something. Yes, sir.
Yeah, basically, I want to ask Dr. Vilas. So, what is the indication to start the injection Febrile within 24 hours?
Sir, our unit protocol is for ELBW babies. We are starting injection febrile on admission because sometimes in night echo is not possible immediately, and on next day we are doing echo and.
Vilas, yeah.
Yes,
basically we are doing one study, randomized control trial, like one study in 2 groups. So in ELBWs in one group we are doing echo and then starting the brain, and one we have started with the prophylaxis without doing an echo, just to see the outcome. So we have started. So this baby was in the group of injection will be started, and then till we give till 48 hours, we repeat an echo at 48 hours.
Sir, your voice is echoed.
Okay, sorry. Yes, sorry. So if the baby at 48 hours, if the PDA is non-HS PDA and it is closed, then we stop the fibrinil. So it is basically the baby was in the limb of fibrinil. So that's why the fibrinil was started.
So is it prophylactically less than 28 weeks is to be started, right?
Yes. We are doing this study because so less than 28 weeks and less than 1 kg ELBW. So actually we had a few cases in which we got late. Like normal protocol is to do an echo at 12 hours of life and decide about this. But if the baby comes in the night and by the time, so we had few incidences that there was an increased incidence of pulmonary hemorrhage in these babies. So then we started this. We just wanted to see the outcome, how it is, like whether the pulmonary hemorrhage incidence decreases and BPD decreases or not. So this is why we have started this study.
Okay, great, wonderful. So no currently standard guidelines, but you are trying to compare with this, right? Go ahead.
At 24 hours of life, screening head ultrasound and US abdomen was done, which was normal. As echo in echo, there was no PDA, so febrinil was stopped at 48 hours of life. At 72 hours of life, septic screen was repeated, suggestive of CRP of 58.6. So antibiotics were upgraded to second line antibiotics. After that, UVC was removed on day 4 of life and PICC line was inserted. Blood culture final report was negative, suggestive of no growth. By day of life 4, injection amino 1 increased to 4 gram per kg per day, and injection dopamine was tapered and stopped as baby improved. On day of life 5, CRP increased further, so we started injection polymyxin B, and injection amikacin was stopped. On day of life 6, baby was shifted to bubble CPAP with a PPOP of 5 and PSU of 8. On next day, high flow trial was given, but due to multiple episodes of apnea, again baby shifted to bubble CPAP, but apnea was continued. So chest X-ray was done, and which was suggestive of mild fluffy opacities, and ABGA suggestive of pH of 7.19, CO2 of 74. At the time, electrolytes were normal. 2D-co was repeated, which was normal. Dose of caffeine was increased to 8 milligram per kg per dose. So we have again put baby on the non-invasive ventilator. After that, head ultrasound was done in view of multiple apnea, suggestive of changes of periventricular leukomalacia. After that, episodes of apnea decreased, and gradually non-invasive ventilator settings were tapered. On day of life 13, 1 unit of PCV was transfused in view of hemoglobin of 9.5 with PCV of 28, and baby on non-invasive ventilator requiring FiO2 more than 40%. After that, baby was weaned to bubble CPAP and then to high flow. Follow-up HUS and on day of life 19, suggestive bilateral dilated both lateral ventricle and third ventricle with internal echoes and septa. Right, diameter of ventricle is 12 mm and 11 mm. And a possibility of meningitis with changes of PVL in bilateral periventricular region. So lumbar puncture was done. and CSF sent for examination on 15th of February. Total cells were 6,300, 80% neutrophils and rest were lymphocytes. Protein contained is 733 gram. Sugar was 15. RBCs not seen. CSF culture was also done, which was suggestive of no organism. Antibiotics were started in meningitic dose. On follow-up, biweekly head circumference monitoring was done during a stay, and we have done Lebanese index checked on head ultrasound, and RI was increased, suggesting of hydrocephalus. So decision was made for ventricular tapping with intraventricular injection following intraventricular injection colistin. A repeat CSF examination by ventricular tap on after 1 week suggestive of total cells were 5,000. Initially were 6,300, and which were neutrophilic cells. Protein was high and RBC is not seen. For increasing ventricular dilatation, we have taken pediatric neurosurgeon opinion. So he advised CT scan of brain. The CT brain was suggestive of all ventricular dilatation, right and left lateral ventricle, third and fourth ventricle with parenchymal thinning, and also suggestive of changes of meningitis and widening of sutures. Plan was made to insert a ventricular reservoir, Omaya reservoir placed to drain the CSF at 1 month of life of 27th of February. After that, after Omaya insertion, CSF tapping was planned twice a week, and intraventricular injection colistin was continued. Repeat CSF examination suggestive of cells are decreased 2,500, 80% of neutrophils, and protein of 485. Now, feeding history. Minimal enteral nutrition was started at 15 ml per kg per day at 12 hours of life. As baby was stable, and baby tolerated man well. So, RT feeding was gradually increased to by 10 to 15 ml per kg per day, and baby was on full feed on day of life 7. Fortifications were started on day of life 8, but on day of life 9, due to the multiple episodes of apnea and abdominal distension, the feed volume was decreased to half 50%. Rest of IV food was given. On day of life 13, due to persistence of abdominal distension, X-ray abdomen was done, suggestive of dilated bowel looks, and blood report suggestive of thrombocytopenia and acidosis. So baby was kept NBM considering NEC. And again on day of life 16, after 3 days of NBM, baby again minimal enteral nutrition was restarted at 15 ml per kg per day and increased to full feeding as tolerated well by baby. Now baby is on full RT feeding, 14 ml too early, PFI of 170 ml per kg per day with fortifications of feed with a calorie content of 136 kilocalorie per kg per day. To summarize history, extreme preterm 27 plus 5 weeks, ELBW, AGA female baby, now 42 days of life with chronological gestation age of 33 plus 5 weeks, was admitted to NICU in view of respiratory distress syndrome and preterm care. Baby was given 1 dose of surfactant, phototherapy, 4 units of FFP, and 2 units of PCV. Baby also had meningitis and hydrocephalus. So Omaya insertion was done and intraventricular tapping and colistin was planned. ROP examination was done at 2 weeks of age, suggestive both high immature retina on zone 1 and no plus disease. Repeat after 2 weeks, suggestive of same finding, and follow-up examination planned after 2 weeks. So diagnosis after history, preterm 27 plus 5 weeks, ELBW, AGA, respiratory distress syndrome, coagulopathy, neonatal hyperbilirubinemia, apnea of prematurity, NEC, anemia of prematurity with probable sepsis, and post-meningitic hydrocephalus. For that, Omaya was done, and periventricular leukomalacia with anemia of prematurity. Now, on examination, baby is in radiant warmer in supine position with partially flexed posture in sleeping state on high flow, FiO2 of 21% flow of 4 liter with IV cannula in situ in right foot with orogastric tube in situ. Vitals on examination, temperature was normal, euthermic and warmer temperature 36.8 degree. Heart rate.
Excuse me, Dr. Just before,
Yes,
tell me regarding what is this Western index criteria for how frequent you tape the CSF.
Yes, sir. On Doppler exam, Doppler of head ultrasound, we are doing anterior cerebral artery. In anterior cerebral artery, we are doing resistive index, and if normally it is 0.6 to 0.8, but if more than 0.85, it's suggestive of hydrocephalus, and so that indicative of hydrocephalus, and for that CSF tapping is planned, and resistive index was done twice a weekly.
Okay. So how frequent you tapped? How frequent is that? Twice a week, or is it more than that?
Yes, sir. After yes, sir. We can tap on alternate day also, or twice a week.
Or other than resistance index, is there any value of hydrocephalus ventricular index? Is there any ventricular index like?
Ventricular index.
Yeah. So size of the ventricle.
Hello, sir. Sir, actually, that one is the Lebanese index. That is a line of action, which means. But now, since the Doppler thing has come in and it is very more sensitive and specific, so now in our unit we have stopped following the Lebanese index. So what we follow is only the Dopplers of AC or NCA, and if the Dopplers of RI are more than 0.85 and they are more than 20% of the previous RI, so then that is a line. What we follow the line of action in Lebanese index. This is a line of this is a time of action. Like we do take the action of tapping if the RI is more than 0.85 and it is more than 20% of the previous RI value. This is what we follow in our unit. We no longer follow the ventricular index or Lebanese index now.
Okay. So basically, though there are two criteria, na? So we can use the ventricular index, but you are following the this Lebanese index, right?
Yes, sir.
Yes.
Okay, fine.
Okay. Baby's vitals, temperature was normal, euthermic, heart rate was 142 per minute, and pulses were well palpable. Respiratory rate 78 per minute, and saturation is 98% in right upper limb, preductal, and 97% in left upper limb. Anthropometry on admission, baby's weight was 810 grams, length is 33 centimeter, and head circumference is 24.5 centimeter. Suggestive of weight and head circumference on 10th centile, and length is at 3rd centile. Current parameters, baby has gained weight of 942 grams, and length 34 centimeter, and head circumference is 26 centimeter. All were less than 3rd centile on gross floating. At 34 weeks of gestation, all centiles were below 3rd centile. From head to toe examination, on examination of head, anterior fontanelle bulging, size is 0.8 by 0.8 centimeter. PF was just tip was inserting, and there is no swelling over the scalp. On face, there was no dysmorphic features. In eyes, there was no cataract, no subconjunctival hemorrhage, no icterus. On nose, pressure sore of present over the nasal bridge. Ear, no preauricular tag or ear recoil is slow. Oral cavity, there was no natal teeth. Tongue, there was no asymmetry or deviation. Feeding tube present, 6 French diameter, fixed at 14 centimeter. There was no cleft lip or cleft palate. On neck examination, there was no mass or any swelling. Chest, normal shape, mild subcostal retractions and intercostal retractions were present. Nipples are barely visible. Abdomen, there was no distension, visible bowel loops, or umbilical cord is fallen off, and abdominal girth is 22 centimeter. On back, there was no tuft of hair, and genital female phenotype, clitoris is visible, labia major are not covering the minora. On extremity, upper limb, there was no deformity, bilateral brachial pulses were well felt, IV cannula in C2 in right forearm. In lower limb, bilateral femoral pulses were well felt. No evidence of developmental dysplasia of hip or club foot. New Ballard's foot at the time of 12 hours of life, which was 26 to 28 weeks. Babies between 26 to 28 weeks. On systemic examination, respiratory system, respiratory rate of 78 per minute, abdominothoracic type of breathing, and there was mild SCR and ICR present. Breathing movement, bilateral symmetrical chest movement present. Air entry bilateral equal in all areas with clear and no other sounds. On cardiovascular system examination, heart rate were 142 per minute with regular rhythm. Apical impulse is visible in fourth intercostal space in mid-clavicular line, and heart sounds were normal. There was no murmur. Per abdomen examination, inspection temperature was normal. There was no abdominal distension or visible bowel lobes. Umbilicus was central. No umbilical hernia. Umbilical cord is fallen. Palpation, abdomen soft, no organomegaly. And auscultation, bowel sounds were normal. Now, central nervous system examination, higher mental function, baby in sleeping state but arousable. Cranial nerves examination, first cranial nerve not assessed. In second, in both eye pupils bilaterally equally reacting to light. And 3, 4, 6 cranial nerve, eye movement present in all direction. And fifth, cranial nerve 5, rooting and sucking present. Cranial nerve 7, no facial asymmetry. Cranial nerve 8, examination, startle response present. On 9th and 10th cranial nerve, there was no pulling of secretions and with normal gait. And 11th cranial nerve, the head and neck movement is normal. 12th, there was no deviation of tongue. On motor function examination, baby is lying in supine position with all four limbs are partially extended. Tone, there was increased range of movement. Scarf sign, elbow crosses the midline. Then here, heel to ear, heel is touching the ear. Adductor angle is 60 to 80 degree. Ankle dorsiflexion is 60 to 70 degree. Power in all four limbs is more than 3 by 5 in all four limbs. Neonatal reflexes, rooting is present, sucking present, Moro's partial response present with grasp reflex weak and glabellar tap present. Now, final diagnosis. Preterm 27 plus 5 weeks, extremely low birth weight baby, appropriate for gestational age with respiratory distress syndrome and neonatal jaundice, with coagulopathy, apnea of prematurity and anemia of prematurity, with probable sepsis and having post meningitis hydrocephalus. With for that OMI was done, and PVL changes and necrotizing enterocolitis with anemia of prematurity.
Yeah, hello.
Yes, sir.
Hello, am I audible, Dr. Vilas?
Yes, sir. Yes, sir.
Okay. So I think sorry if first half of I missed your presentation, but excellent presentation, very well managed case. And just a few quick question I just had in my mind. So after the concluding, you written the probable sepsis. So means early markers were not suggestive of any sepsis, even though the baby has got a full in state of shock. So what was the reason behind for that?
Sir, there may be a perinatal depression as baby went in apnea, and also during transport, baby may be hypothermic, and as it is as she's low birth weight, extremely low birth weight baby with 800-gram weight.
Okay. So probably the prematurity and the birth asphyxiation.
Prematurity and yes, sir, perinatal depression.
And what is the indication of doing repeated, CSF analysis for that in this baby?
Sir, initially head ultrasound suggestive of internal moving echoes suggestive of meningitis. So we have done, sir, CSF exam, lumbar puncture and CSF examination. First examination suggestive of meningitis, cells of 6300. So we have repeated after changing antibiotic. We have repeated CSF after 1 week, and cells were decreasing. On repeated head ultrasound measurement and on Doppler examination, it was suggestive of hydrocephalus. So
my one point is when you did the first ultrasound of the brain, when you did your first ultrasound of the baby?
Sir, at 24 hours, first day of life.
First day of life, and that time there was no IVF or nothing.
No, sir. No,
okay.
Sir.
Okay.
And sir, second ultrasound on day 6 of life suggestive of changes of PVL, periventricular leukomalacia, and
you notice the changes at what days of life?
So 6th day of life.
6th day of life. So probably
yes,
the 6th day of life PBL changes is little unlikely, don't you think?
But sir, if there is
Dr.
Sir,
Mohit Mohit Saini is the better person to be asked. Sir, is it okay to
Yeah.
consider D6 of life?
No,
PVL?
actually, the very nicely question you asked, very nice, good question, because that is the whole crux of this case to be very interesting. So actually, on first day one, there were not much like thing like what we do. There are two people who are doing neonatologists, like we are doing the head ultrasound, and the radiologists are doing the head ultrasound. So like I think so. Something was missed at 24 hours of ultrasound, which was being done, because the next ultrasound, which was being done by us, it picked up that they were thinking of PVL changes, but actually there was intraventricular septae were being formed, and it was the changes of meningitis, basically. So basically, it was intrauterine meningitis.
Yes,
So it
yes, yes.
wasn't picked up. Yeah,
Because
so it wasn't picked up early.
what comes into my mind, because the CSF protein is persistently very high for almost repeated, CSF analysis was done. PVL changes at 6 days of life, it is very unlikely, and that probably some intrauterine insult or intrauterine stroke may have
Yeah.
contributed for that.
Yeah, so it was intrauterine meningitis. So that was interesting
that
about
is
this
why.
study. Yeah.
Okay.
So because the second day only, there were significant changes in the head ultrasound.
Okay.
It wasn't clinically, there was nothing, and cultures were negative, septic screen was negative, but it was being first picked up only on the head ultrasound, which was being done on day 1 and day 2.
Okay, and
That's why we did CSF.
And one point is again in against it, because there was no sepsis at all. There was no IVS, so why would have the baby so much of high CSF protein and later on baby developing hydrocephalus, that is obstructive hydrocephalus.
Yeah, that is something very interesting in this baby. 800 grammer with all these things and presenting with intrauterine meningitis. That was something very interesting about this baby.
Yeah, so I think antenatal, perinatal aspect for the mothers, that can be taken for, in a more elaborate fashion. Probably, we must have looked for, high vaginal swab or something, that could probably answer why the baby has got so much of high protein despite all these things.
Yeah.
Okay, Dr. Vilas, that's all from my side. The rest, Dr. Dhananjay Mangal, you please come. Hello, Dr. Dhananjay.
Sir, please unmute.
Hello. Hello.
Hello.
Hello. Are you hearing me, Dr. Will?
No, sir. Sir, your voice is breaking.
Hello.
Yes, sir.
Now my voice is clear?
Yeah, sir.
Hello. Dr. Vilas?
Hello.
Dr. Vilas?
Yes, sir.
My voice is clear.
Sir,
Is
in
clear?
between, your voice is not audible.
Okay, might be because of some.
Hello.
But so well explained, very nicely presented and elaborated way. Wonderful presentation, and I think there are some so many things to be learned from this case. Yeah. So regarding at what time we have to, how frequent we have to do sonograph, head ultrasound, and febrile is to be given prophylaxically or not, and what are the indications for dexamethasone or betamethasone, right? So, and we have to do sonography screening more frequently rather than twice a week. I think so. So we can pick up earliest possible plus changes, and you can consider this ventricular index also, because ventricular size more efficiently we can do through this ultrasound, right? So
Otherwise, nutrition point and respiratory part, you did wonderful. I think everything is on. And how many days you had given antibiotics? So now,
So we have total antibiotic in meningitis dose total 4 weeks. We have stopped yesterday. 4 weeks, sir.
so 4 weeks, like polymyxin or
No, sir.
cholesterol. Polymyxin.
Meropenem. After that, after detection of meningitis, we have started meropenem in meningitis dose.
But you didn't mention that history. I think you mentioned the
Sir,
polymyxin. I think.
sir, I mentioned that meningitis dose antibiotics were started after CSF.
Okay, so you didn't mention the name of the meropenem. Anyway, okay, so meropenem has been given for 4 weeks, and polymyxin initially started. So
it was stopped after 7 weeks.
So there is some. Is there any blood culture and CSF culture? So have you done the repeat blood culture also? Because
Sir,
our aim is to detect the bug first.
Sir, blood culture twice was negative. Twice we have done 2 times blood culture, which was normal, suggestive no organism.
So just one
Dr.
person
Ravi,
is asking.
just think.
Yeah, Dr. Dhananjay and Vilas, one doctor is asking, have you sent fungal culture? Because
No, sir.
that can be
No, sir.
a possibility. So that is one thing which our audience is asking.
Yeah,
Okay.
that is not see, we use backtest system. So backtest system in sensitivity wise, it is good enough to pick up the fungus also. If we have to be very specifically see the fungus, then we have to do the fungal culture. Otherwise, backtest is good enough to capture the fungus also.
Okay. One more question for Vilas is somebody is asking, full-term baby PDA 4 asymptomatic, should be treated or not?
Sir, if baby is hemodynamically stable and there was no any other clinical features of PDA and the baby is on off oxygen, we can wait, sir.
Perfect. Yeah. Noise by right, we can wait.
Yeah. So only thing is why he has specifically mentioned 4 millimeter, because that is a number which pediatric cardiologists follow very stringently. If any PDA more than 4 millimeters and above, they are very aggressive in treating, irrespective of the gestation. Even in term babies, if in term babies the PDA is 4 millimeter and above, they will be aggressive in treating. But as Vilas rightly said, if it is hemodynamically stable and good, then we should just wait and see, follow.
So is there an indication the prophylaxis start of antifungal, Dr. Vilas? If there is
For antifungal prophylaxis, sir?
Yeah. Antifungal prophylaxis.
Yes, sir. Sir, in ELBW babies, we are giving antifungal prophylaxis after if central lining C2 for more than 7 days or baby if baby's culture was positive and if baby had meningitis, then we are giving antifungal prophylaxis.
Dr. Vilas, in this case, because we are treating the proven meningitis along with the sepsis and coagulopathy, so must be the DIC and multiple organ involvement. So on or higher antibiotic for the longer period, should we start antifungal?
Yes, sir.
Okay. So you didn't give in this case, right? Dr. Mohit?
Yes, please.
Dr. Mohit, should we start prophylactically if baby has an antibiotic, prolonged broad-spectrum antibiotic with meningitis and such a sick baby? Should we start prophylaxis antifungal just to cover up the things?
Yes, sir. Actually, what is the criteria which we usually follow for the antifungal in most of the units is, if in your unit the fungal rate is high and there are endemic in your unit, then you should give, if the baby you are starting on antibiotic, you start with the prophylaxis of antifungal. But if your 2 years data shows in the unit that your fungal rate is very less, that is less than 3%, then you can stop prophylaxis. Previously,
Okay,
our
that's-
rate of fungal unit rate positivity was more than 30%. But last for 1.5 to 2 years, we have come down to almost 2%. So we are now in the zone of going away from this. So that is
Oh,
the
great.
criteria
So
we
that's
are
very,
following.
very nice. Very nice to hear from your unit. Mohit, is a great thing. For last 1.5 to 2 years, in spite of the big busy nursery. So it's very nice to have your confidence to not to start. That's great.
There are two more questions directly. One is for ELBW child. Do you have any protocol to start erythropoietin?
We are not.
No.
So there is one trial, but we are not using erythropoietin. We are not doing.
I can share the experience in our unit. We were not using erythropoietin at all. Basically, it is for to decrease the anemia of prematurity blood transfusions. But in some of the few prominent units in India, it has been seen. And I happened to be an examiner there. So I thought if 2 or 3 units are being using it, there were few studies, but not strong. Even the CPG guidelines did not recommend that. So we started this practice in our unit of erythropoietin, uses of erythropoietin in ELBWs. And we did for 2 years. Then what we did, we compared the data pre-erythropoietin and post-erythropoietin, the usage of blood units for the premature babies. And what we found was there was no difference in pre-erythropoietin and with erythropoietin. On the contrary, we found there was an increased NEC rate during the time. That was not very, because there were multiple confounding factors were there. But we found that there was an there's some increased rate in NEC. So that's why we stopped erythropoietin, because it did not decrease significantly decrease the uses of blood in our ELBW. So data was similar what it was pre-erythropoietin. So then we used for 2 years, then we stopped. So again, it coincides with most of the studies that shows that erythropoietin is not useful in ELBWs for decreasing the blood transfusion rate.
One more question for Vilas. What was the PCT and what is the cutoff of PCT?
So procalcitonin.
Yeah. So have you done procalcitonin in this child?
No, sir.
No. Okay. And what is the cutoff? That is also the person is asking.
This is again something very interesting, because some of those units, they follow procalcitonin. In our unit, basically our to monitor, it is not the single value either of procalcitonin or CRP or whatever you use. It is a serial monitor. It is a serial number. It gives you the trend. So that's why in our unit we don't do PCT. We do CRPs, blood culture, and CBC, and we follow the trends like that. So we don't use PCT in our unit unless we have a confusion that whether it is a viral infection, fungal infection, or a bacterial infection. Otherwise, we don't use PCT in our unit.
Fine. So we are dot on time, 4:28, and almost many questions were answered, and a wonderful case was also presented. Can I request Ankita to present
Yes,
a
sir.
certificate?
Yes, sir.
Yeah.
Give me a minute, sir.
So on behalf of Forum-Gujarat, we are thankful to both of our experts for being there today with us. Certificate of appreciation is presented to Dr. Mohit Sani for to Vilas for preparing a PG case presentation in Forum-Gujarat State Chapter's Neonatal Pathshala. We are also thankful to Dr. Dhananjay Mangal for being an expert, and Dr. Ravi Sachin. In spite of having an exam in the college, he joined. We are thankful to Dr. Somshekhar also for being his proxy in the first half. Thank you so much, everyone, and thank you to Vilas Kawar, Dr. Vilas, for presenting such a wonderful case. We'll be meeting next Wednesday on 22nd March, Focus Series 3, Lecture 3. So everyone can join on YouTube link as well as the ClearNet platform by the same link. To see you on next Wednesday at 3:30. Thank you so
Thank you
much.
everyone for sharing their valuable insights. We are more than grateful to everyone present over here.
Yeah,
Hoping
Dr.
to
Ravi.
meet you again.
Yeah, Dr. Prashant, I'm really so sorry for
No, perfectly fine. You were there with us, so fine. And we will be calling you again also. And thank you so much, Dr. Dhananjay, also.
Thank you so much. Thank you
Thank you
for
very much, sir. Thank you very much. Thank you.
Yeah, we can end the meeting.